Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
So at the very least, they're removing the justification that the payers were using based on our previous consensus statement that basically kind of endorsed step care. And certainly what we're doing with this consensus statement is calling attention to this now overwhelming evidence in support of using these therapies.
Welcome to Talking Head Pain, the podcast that confronts head pain head on. I'm your host, Joe Koh, Director of Therapeutic Area Growth and Integration at the Global Healthy Living Foundation, as well as Co-President of GHLF Canada. I've been a migraine patient for over 20 years, so I know firsthand how debilitating this disease can be. I'm here at Dr. Andrew Charles, who is a professor of neurology at UCLA and director of the UCLA Migraine and Pain Program. He's also the current president of the American Headache Society. We're here to discuss some late-breaking news that the American Headache Society published exciting updated guidance on migraine prevention therapy. This document, which I had the chance to review yesterday, could have profound positive impacts for the patient and provider community, those that are dealing with migraine. So let's jump right in. Dr. Charles, what was your role in this paper, and why did the American Headache Society choose to publish and look at this issue?
Well, I'm the first author on the paper amongst a group of other very well-known headache specialists and leadership of the American Headache Society. I'm also someone who was involved in the sort of conception of the project along with my colleagues. It's something that we've been thinking about for some time. And as president of the American Headache Society, it's also something that we've been hearing about from our members for quite some time. It's mentioned in the paper. We heard from our membership at our town hall meetings and at other less formal venues where they were basically giving us an earful about how we really needed to put this out and update the previous consensus statement.
And can you elaborate on the significance of this statement and position that is saying that CGRPs should be considered a first-line treatment? We know historically the first-line treatment for chronic migraine have been therapies that aren't developed specifically for migraine.
That's right. And so really it starts with the notion that these are migraine-specific therapies. So they're based on a really solid foundation of evidence that CGRP plays a primary role in generating migraine and that inhibiting CGRP is an effective way of treating migraine. So this is really a contrast to the previously available preventive therapies that, again, as you mentioned, were developed for other indications and just sort of borrowed for migraine. So that's kind of where we start. The previous consensus statement endorsed what's called step therapy, which means that before getting to these CGRP targeting therapies, one had to try at least two other established preventive therapies. And those include things like beta blockers, seizure medications, antidepressants, in the case of chronic migraine, also Botox. And so the notion was that, again, in order to justify getting one of these newer ones, one had to try something else first. Since that last statement was published, even just over the last 3 years, there's been this explosion of evidence, both clinical trial evidence and what we call real-world studies, showing that these therapies are, number one, exceptionally effective, especially for a subset of patients, and number two, particularly well tolerated, so without the side effects of a number of the other therapies. And furthermore, there's now more than 10 years of evidence, including the clinical trials, showing that serious adverse effects with these therapies are extremely rare. So they're safe, they're well tolerated, they're effective, and the cumulative evidence for these therapies is just exponentially greater than for any of the other established therapies. And so it basically, was time to put this statement out that it really does not make sense that we should try other therapies first before trying these therapies for which there's now overwhelming evidence.
Yes, I found that very interesting, particularly the discussion around side effects with the older, less targeted therapy options. How does the reduction in side effects and the increase in efficacy impact a patient?
Well, it's profound. I mean, starting with the efficacy, one of the pieces of data that is really extraordinary that's come out from the clinical trials especially, but also with some of the real-world studies, is that for these therapies, they're often what we call super responders. So people who have not just a 50% reduction in headache frequency or migraine attack frequency, which is kind of the previous standard for preventive therapies, but we have people having 75%, even 100% reduction in their migraine attacks, which is, if you think about that for a patient who's typically had been in the past losing 4 or 6 or 8 or 10 days per month to migraine, to make that 1 or 2 is just an absolutely profound effect. So we don't typically think as much about the adverse effects, but if you're dizzy, if you're nauseated, if you're getting weight changes, if you're sleepy, you have cognitive dysfunction, those are all things that, even if you're having benefit in terms of migraine, those added now new adverse effects are going to be something that impair you and disrupt the quality of your life in other ways. And so that's, again, why this is something that we're so excited about these newer therapies, is that for most people, they're really very well tolerated.
Yeah, that's super exciting and personal for me. I'm thinking of my N of 1 story of being on an older medication and doing what all the doctors told me to do, which was to get healthy and lose weight. And as I started to do that, that medication was causing me to be dizzy and pass out and causing extreme low blood pressure, which hasn't been the case with the newer medications that I've been on. I've been able to get off of that and get on newer treatments and not even realize until I've been on them that I was living suboptimally, even when I thought I was doing okay and I was having a mild headache almost every day. My migraine attacks were better, but my headache symptoms were still there. On these newer treatments, my headache symptoms aren't there. I get breakthrough headaches or migraines, but it's amazing.
Yeah, and we hear that day in and day out. It really is gratifying. I actually like saying that we hear the words, "my life has changed," more often in the last few years than we've had basically in my entire career. And so it's enormously gratifying. The other thing is that your experience of not knowing what it was like to be free of these, or to just to be capable of feeling better, is also something that we hear about. These people come in and just say, I had no idea how it felt to have this sort of clarity of thinking, not having these sort of residual effects of migraine attacks, the post-traumatic that lasts in many cases for a day or two after the headache resolves. And so that sort of clarity of thinking, the energy, the just sense of well-being that can be produced when you really effectively treat migraine is something that is kind of a revelation to a lot of people. And it's really, again, as providers, it's wonderful for us to hear that.
So we're speaking about real-world evidence, clinical data that has been established in studies, experience from both the provider and the patient around these therapeutic options and how they improve quality of life. Is there hope that this position paper and statement will help move insurance companies to have less burdensome prior authorization or utilization management step therapy protocols?
Yeah, well, we can always hope. So at the very least, they're removing the justification that the payers were using based on our previous consensus statement that basically kind of endorsed step care. So that's at least off the table. And certainly what we're doing with this consensus statement is calling attention to this now overwhelming evidence in support of using these therapies. But the elephant in the room is always cost. And we do address that in this statement and make a strong case that it's not simply the cost of the medication, but it's also costs of acute treatments that might be reduced. It's the cost of healthcare that people are seeking because they are having persistent or poorly treated migraine. And on the provider side, enormous costs in terms of time that we spend trying to get treatments justified and get them into the hands of patients. And for the patient then, of course, which is often sadly not really well considered by the insurance companies, enormous socioeconomic costs of migraine, lost work, lost quality of life, lost family time. And so those are things that we're urging the payers to consider as well. So whether or not they do that, we'll see. But, we wanted to try and make some progress here and really let the payers know that we feel very strongly about this. And we'll see if there's any sort of response to it. but at the least we can get it out there. Already, since it came out on Monday, we've been sending it to insurance companies as justification for trying to get people on therapies. I should point out, too, that we're not saying that these therapies are the first line option. We are saying that they are a first line option. And there certainly may be individuals for whom the established therapies, and especially Botox for chronic migraine, but also other therapies, may actually be the ones that we choose. But we don't want to have to choose those first if we deem it appropriate to basically use these newer therapies.
That's a really good call out for us to just highlight. It's really underscoring the importance of the relationship between the provider and the patient. And
Absolutely.
this consensus statement is saying, let us practice medicine and let the patients have the treatment that we believe with shared decision making and all of the important things that we do together with our providers and patients, have the best treatment at the right time for that patient. And just want to send my thanks and appreciation to AHS for pushing this out and contacting the insurance companies, because it might help, the person living in rural Oklahoma get access to treatments that they might not have readily accessible otherwise.
Yeah, that's right. And also other providers, it might make primary care physicians more amenable to using these therapies if they see that we're endorsing them as very safe and well tolerated and also effective.
That's a great point. I remember when CGRPs came to the market, I asked a primary care physician that I know, would he prescribe them? And he said, I would leave it up to the specialists. I don't know enough about it. So this is another piece of information that can help so many patients who don't have access to headache specialists, let alone neurologists, to potentially help educate their providers.
Yes, that's right.
How should patients bring this up with their providers, this consensus statement?
Yeah, well, so it's an interesting balance that sounds like you've experienced where, depending on the provider, ones who don't let their ego get involved, they're perfectly happy to hear these things from patients. Others might be a little bit resistant to be told what they should be doing. So you have to kind of navigate that sort of balance. But I do think that it is something that it's entirely reasonable to just basically put this consensus statement in front of them and say, what do you think about this? And I think the statement basically doesn't include all of the literature because it's overwhelming amount of literature, but I think it's a reasonable summary. And I think we try and make succinct and compelling points that even a primary care physician will understand. I can tell you that headache specialists and neurologists, well, not all neurologists, but some neurologists are already considering CGRP targeting therapies in the same way that we're putting them forward. But I do think it might be a useful tool for patients to have as kind of advocating on their own behalf. And now actually what we're saying is pretty much what is being said worldwide in other organizations as well. So it really, I think, adds some nice support to patients' ability to ask for these new treatments.
My last question just came up as I was listening to what you were saying. Is there any part of the consensus statement that talks about combination therapy?
Not specifically, but there's two ways of thinking about combination therapy. For most people, they still need acute treatment because the preventive treatment isn't 100% effective. And we don't really address that too much, nor do we address the fact that what we're seeing with these new therapies is that most of the time they don't need combination therapy, which is wonderful because when you mix up different sorts of non-specific therapies, then that potentiates even further the potential or the possibility of adverse effects and sometimes serious adverse effects. So that is not something that we address. But since you brought it up, it really is one of the advantages of these treatments is that very, very often, more often than not, we don't need additional preventive therapies. We can just use these as what we call monotherapy.
Amazing. Was there anything that I didn't ask that you feel our audience on Talking Head Pain should know?
No, just I'd like to express my appreciation for giving me an opportunity to talk to you. And these are just extremely exciting times for our field and for our patients. And it's great that you're doing this to inform people so that they can stay on top of what's going on. I can tell you there's even more new exciting therapies on the near horizon. And so these approaches are basically not only helping people feel better, but they're also helping us understand migraine better so that we can kind of take them back to the laboratory and the research settings to be able to then develop even new and better treatments. So there's enormous momentum right now and enormous excitement in our field. And we're very happy to share that with our patients.
I love that. And I was just at a dermatology meeting sharing with someone that was telling me that they have uncontrolled migraine. And I said, well, that is horrible. But if you're going to have migraine at any point in history, right now seems to be the good time to have migraine.
That's exactly right.
Just wanted to, again, share the appreciation. And it's important for our folks, patients, and other providers to know that the association like the American Headache Society are pushing, sometimes behind the scenes, very often behind the scenes, to increase knowledge and help move patient care forward. This was a very visible and direct way that we can see that. And it's important to acknowledge when that happens because we often feel disconnected from our providers and from medical associations. And often the information that's shared is way above our heads as patients. So this is a really good example of the good work that the American Headache Society does and the leadership pushing forward patient care.
Yeah, thanks very much. And again, thanks for the opportunity to be with you.
Thank you for listening to this episode of Talking Head Pain, the podcast that confronts head pain head on. If you have any questions, thoughts, or suggestions for us, you can send us an email at podcast@ghlf.org. If you enjoyed this episode, please give it an honest 5-star rating, write a positive review, and spread the word by sharing it with your friends and family. It'll help more people like you find us. I'm Joe Coe, and I will see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.